Arvin,
Hey.
welcome.
Nice to meet you.
Good to finally meet you in person.
All right.
Welcome to our micro lab. This is where we practice doing microsurgery. I'll tell you all about what that is, but basically it's suturing teeny tiny blood vessels under a microscope, which we do clinically for various reasons. And we got everything we need here. I'm gonna put you through your paces.
All right.
See if I can show you how to do it, check
Sure
your
thing.
steady hands and all that. This
right.
area is where we've got the microscope and all our little supplies. We're not gonna hurt any animals. We're just practicing on little tubes and stuff like that.
All right.
And yeah, I've got a whiteboard here. I can draw out kind of some of the stuff we're gonna do in a second for you. But
right. Perfect. Let's get
welcome.
into it.
Let's get going. All right, so I wanna show you why we're learning how to do this, okay? Let's take a clinical scenario. Imagine this is your leg and you get in a motorcycle accident. And now you've got in here a broken bone. Seems like no problem, right? Orthopedic surgeon could put a plate on that. Ah, but you were on a motorcycle and all the skin around here got ripped off. Now you've got a big open wound right over the fracture site. So if you put your plate on that, it's just gonna be the air going right down to it, right?
Right.
So you gotta do something to get skin coverage back over that area. So what we end up doing are these things called free flaps. And to understand this, I've gotta draw in the blood vessels in your leg. So let's imagine this is just a simplified artery. And arteries generally always have veins running with them. Okay. And what we do is we take a piece of tissue from somewhere else. So let's imagine you take a piece of skin off your body, like your thigh, and you just take it off and sew it back on here. It would be kind of like taking it off and putting it on the table for a week. You know, it's just going to shrivel up and die. So for that tissue to live, it's got to have an artery and vein pumping blood in and out of it, so it can live down here just like it used to live up there. So let's now draw in our flap, we call it. That's going to go in here and cover up the wound. So there's the skin, it'll have a little layer of fat underneath it. And then this flap is going to have also an artery and a vein. So we disconnect these from where we take it from, and now we've got to reconnect them in here. So we would divide these blood vessels, connect the vein, and then divide this blood vessel, connect the artery. And the reason we call it microsurgery, and now you're getting blood pumping in, you know, nourishing the flap, and then blood pumping back out, making sure you're getting rid of all the toxic metabolites. The reason we call it microsurgery is because these vessels are not like your aorta, they're small. They're usually between 1 and 3 millimeters in size. So you need a microscope to do it, you need really fine sutures, steady hands, and specialized techniques.
Wow.
That's what I'm gonna test you on today.
All right, let's get into it.
All right. Okay, so come on in here. So I'm gonna show you what we're looking at here. So here's our simulated blood vessel. It's 2 millimeters in size. Each one of these squares is 1 millimeter, so 2 millimeter luminal diameter. And here we've cut it. You know, in real life, we would be not just cutting and repairing the same vessel. This would be from our flap, and this would be our recipient vessel.
Right.
So I'm gonna dilate it open, and then I'm gonna get my tiny little suture ready to sew. So here's the stitch. You saw it, you know, normal sized on your iPhone or on the other camera. And now you can see it under the microscope. Still looks small, but you know, a little easier to work with. Get that stretched out in the right direction there. Okay, so let's get myself set for success here. There's my needle. And now we're gonna start taking teeny little sutures. So I'm gonna take one here at what we call the 0 position. These are a little harder to grab than real blood vessels because they don't have an adventitial layer, but that's okay. Pull it through, brace, as I pull, 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 pull. And now, pull a little bit further, and then I tie a knot. So I'm gonna aim my pickups towards the tail of this stitch. I'm gonna make a double loop around my forcep. I'm going to reposition that a little bit there. There we go. I'm going to grab this tail, pull it down, and there's my first knot. I'm going to come over, re-grab it, pull it down again, come over, tie another throw, pull it down again. Now, do you think with your scissors you can move in here and just cut right there for me on that one tail?
Let's try to do this with my left hand. So
I know, it's left-handed. I'm not going to make it easy on you. You're trying to get into med school. We only want the best of the best. So slide down as far as you can on this and cut it right down by the knot.
Alright.
Closer to the table. I want you to cut it, look, right down
right
here.
there,
We
gotcha.
go. Yep, perfect. Oh, good
There we
job.
go. All right.
He's a natural.
Sure hope so.
All right.
Now,
so I
are
gotta-
these absorbable sutures?
No,
or-
these are permanent.
Okay, gotcha.
So, you know, blood vessels heal in about 5 days, at least on the inside.
Mhm.
So you could theoretically use absorbable suture, but this nylon suture has the proper handling. You know, it's kind of, it's got a rough texture, so even these tiny sizes will hold the knots pretty well.
Mhm.
And then, you know, there's no reason really to make it reabsorbable because the endothelium of the blood vessel will grow over it
Right.
really quickly.
Mhm.
So I'm going to pull it through till it's right where I want it, come down on top of the stitch, aim my forceps towards the tail, wrap it around twice, grab that, and now I'm putting what we call my 180 suture in.
Mhm.
I'm going to come over here, re-grab that, tie another throw, make a loop, re-grab, tie another throw, and I'm going to have you try and cut just this one right there.
All right. Let's see. I really got to resist the urge to just look down away from the microscope.
Oh yeah, it's very disorienting at first. You're doing a great
Yeah.
job though. So come on down, I'll hold this one out of your way in a sec. I want you to try and get, yep, just that. Perfect.
There we go.
Very nice. Okay, now I gotta drag my needle back into the field. You're always using both hands, you know.
Mhm.
You can see it's a little magnetized. See how it's sticking
Yeah.
to that?
Right.
Even a little bit of magnetization of the needle then makes it very difficult to work with.
Mhm.
We do have a demagnetizer if you need it.
See how hard it is for me to grab?
Right.
So yeah, I think I
Yeah.
will take the demagnetizer in just a second here. And in real life, sometimes we use titanium instruments that are not
Mhm.
magnetized. All right, now I'm going to go right in the middle of this here. Take a stitch there. Make that a little bit better. There we go. It's just right. Pull it through. So this is something that's just, when you do it in real life, and you hook this up and you see blood pumping through and perfusing your flap that came from
Mhm.
somewhere else in the body, it's almost like an addictive moment of magic, you know.
Yeah.
The first time I saw this, it just blew my mind in
Wow.
real life, and I knew I had to do it. You know, it's just one of those things that it either just lights up your imagination or you don't care. But for
Mhm.
those of us who are into it, it's just it's like nirvana in surgery.
Right.
Go ahead and cut this.
All right. Try to.
Perfect. Okay.
Now, would you ever do this in just one pass instead of tying multiple times?
Yeah, so there are multiple different techniques, and I use different ones for different things. This is a very simple way of doing it, and you know, if you go through with multiple passes and then tie them all, you end up getting all these loops and long sutures that sometimes it's better to do that because it's a very safe way to make sure you don't get the back wall of the artery.
Right.
But particularly for this demonstration, it might get a little messy and confusing and
I
stuff.
see.
So I think this is a really good way to do it for now. Usually with really small vessels, yeah, you would want to do that because
Right.
here, you know, now this is going to be a little bit collapsed. You know, normally arteries have like a muscular layer that keeps them more stented open. This is I'm trouble grabbing that, just a plastic tube.
Mhm.
Normally it's pretty safe to do it this way without hitting the back wall, but it is a risk. As the vessel gets smaller and smaller though in real life, like below 1.5 millimeters, then you gotta really be careful not to.
Just that.
Good.
Now, how much of a tail do you really want to leave on? when
Oh,
you're
really
cutting?
just like barely enough to see.
Okay.
Not quite at the nut, Now, I'm going to have you, if you can take the scissors out of your left hand and grab that jeweler's forceps. And Natasha, do we have some saline we can squirt on this to get it wet? I'm going to have you grab this tail for me.
Okay.
Uh-huh. Sorry. Just move. Good. Perfect. Now pull it towards yourself a little bit. Pull it a little bit more flat down towards the table.
Gotcha.
Good. See how that bumps that up for me?
Yeah.
And shows me where I need to go. And I'm just going to scoot across like that. Take my next stitch. Good. Now you can let go. You're doing great.
Sure hope so.
No, you are. You're really doing great. You could definitely learn to do this. There's no question.
Now, one question I always ask surgeons, how much of this is talent and how much of this is just hard work?
It's almost all hard work. I would say among the people I've worked with in surgery, I'm not really at all gifted with my hands, but I've put a lot of my life into doing this. So let's go ahead and cut that one.
Sure thing.
I'll tell you my story later on, but I was never really meant to be a doctor. I was kind of a lazy kid. I didn't do a lot of things that would prepare me for this, but I've just dedicated myself. Oh, thanks so much, Natasha. Awesome. That makes it easier to work with. Okay, Arvin, now we got to flip this over and do the back side.
All right.
So let me get this pick up. Oh, and can we have that demagnetizer when you have a sec? Natasha, do we have that demagnetizer?
You sure do.
See, the needle's so small, even a little bit of magnetization will do. Okay, good. Now let's check our back wall and see if we still have a patent lumen. We do.
Right.
Looks good. So I didn't accidentally get anything in the back. I'm just going to run this through the demagnetizer. Do I do the instruments or the needle?
You do both of them at the same time.
Yeah.
You can go ahead and
Go
put it
ahead.
through.
And then do this one. Awesome, thank you. All right, now we got to do the back wall. And as soon as we get through this, it'll be your turn.
All right. Now, I imagine in real life there's a little bit of time pressure as well.
Yeah, so we do think about what we call the ischemic time. So how long the flap is disconnected. You know, theoretically, if it's been long enough, then you could have a, you know, an ischemic injury to the tissue, and then your flap might die. Now, typically, realistically, that's basically 6 hours before that would happen, so
Okay.
it's pretty unlikely, but
All right.
the time it comes into play more often is when you're like replanting a part of the body that's been cut off traumatically, like a hand or a finger or something. Then, you know, sometimes people don't even get to the hospital for 2-3 hours. They're coming from far away. Let's cut this. Then it might be another hour till you get in the OR, and then there's a lot of, you know, it's a messy situation. It's not clean like this, so it might take time before you get to this.
All right.
So that's when the time pressure really comes on. When you're doing something that you've planned ahead, and it's a controlled situation, you know, you're reasonably unlikely to have to be that long.
Right.
But it is something to think about. And I'm just going to kind of scoot across this one here a little bit.
And do you typically have an assistant, like a PA, or?
I've always worked in the training environment. So before this, I was at Washington University in St. Louis on faculty, and now I'm, you know, the program we have here actually is an academic program with residents and fellows. So I always generally have either a resident or a fellow helping me. You know, if you do it enough, you don't need that much help. I can do it alone, or come on down a little lower. Or having a PA, or I used to just have sometimes a nurse. Let's trim that a little bit lower down.
Sure.
But, you know, just having you, what you're doing right now in the OR is about all it takes. Perfect. That's perfect. One more stitch, then you're up.
All right. So this is called an end-to-end.
Correct, yeah. End-to-end anastomosis. So this does require dividing. I'm going to have you grab this one again and pull it towards you. This does require, you know, completely cutting your recipient vessel. So it might be a relatively major vessel that you're cutting. Now, there's usually redundancy in the body, so you can cut one,
Right.
and the other end will still get collateral circulation. But I very frequently am doing an end-to-side anastomosis because I do a lot of reconstruction in the leg and the arm, and you know, your other blood vessels might also be injured, or somebody might have vascular disease where they only have one left, and so you can't afford to cut and go end to end. So I also will frequently do end to side, but that's a little trickier to show here in the lab. So
Right.
okay.
That would be good too.
Ooh, come here, buddy. All right, and now we can take this down. Go ahead and cut the needle off, and then we'll check. We can trim all these tails to make it look a little nicer.
Sure.
So, maybe I'll take that since you're doing your left hand.
Right.
Might be a little easier for me to
Go for it.
move in here and trim it up quick like.
There we go.
Okay, and we'll take a little bit more of the saline. Might be sitting here.
That was right there to your left. Yep.
There we go. Yep. So we'll just kind of clean that up. Okay, and then now this might not be totally watertight because we don't want to spend all day in here, but we'll see if it's good enough that our fluid will stay in there when we take the clamp off. And just maybe strip across it with this thing. There we go. Not a lot of leakage.
I assume you're looking for like air bubbles or.
Yeah, I mean, if we had some of this red fluid leaking out,
Yeah.
that would be it. Now we can try and inject more of this red fluid from the end and see if that's a little bit better test.
All right.
But so let's try and do that. I have to take the pins off. Oh, do I actually? Maybe I'll try leaving. We don't want too much resistance at the end of it because then it will look like it leaks no matter what. But
All right.
we'll see what happens if I take this off. And let's give it a little squirt and see what happens. Okay, we'll give it a little pressure. Looks pretty good.
All right.
Yeah. Doesn't have to be 100% perfect in real life. The vessel's going to heal, and then I bet if we remove this pin, it won't leak nearly as much. Yeah, now it's flowing right through.
All right.
There we go.
Looks good.
All right, Arvin, let's see what you got. Future
right.
microsurgeon, I'm certain of it.
Gotta get into med school first.
I'm shoe in. Okay, so take this and put this in your right hand.
Now are these Castros or?
Oops.
No.
They're not Castros because they don't lock.
Okay,
They're just sort of a micro needle driver.
I see.
It's the locking would, even just like the clicking of the locking and unlocking would be way too much for this. Let's see, so here's your needle. Let me actually get it loaded for you.
Sure. Yeah.
So I'll take that from you for just a second. That's loaded, so when I give it to you, keep squeezing it, okay?
Okay. Yep.
So keep it perfect. Okay, good. That piece of fluid. Sorry. Perfect. Poke through. Look at you.
Man, this is really delicate.
You nailed it.
Okay, then just pass it through.
Uh-huh. Good. Yep, let go there, and then I'll just help you brace it. Ah, look at
There
you.
we go.
Beautiful. Okay, now just pull it through.
There we go.
Now this is a little disconcerting. You have to just kind of pull it off the field. So just keep pulling it towards yourself. Uh-huh, nice and tight. Good. And then we'll do one more. 3 knots is all it takes.
Now,
There you go. Wrap it around. I'm going to hand this to you. Oop, almost. Come from on top again.
yeah.
Uh-huh. You're doing great. Look at this kid.
All right.
You're ready. You pass.
Great.
Ready to operate. I love it.
Nice. All right.
Look what you did.
Looks good.
How's it feel?
feels good.
You're a microsurgeon.
Yeah.
Microsurgeon.
Yeah, many more years to go.